Good afternoon, everybody. This is Ina Flores. I'm talking with you about, I want to thank Dr. Belanki to talk about the webinar today. I just want to give you reminders about the diabetes course for support staff. The next one is going to be Friday, September the 13th, and the Diabetes Education Certificate course, that is a 3-day course that if you are interested to become a CDE, Diabetes Educator, the next one is August 26th to the 28th, but it's completely full. And after that, we have October 16th to the 18th. Well, today we're going to talk about the management of hypertension in patients with type 2 diabetes, and the speaker is Dr. Belanki. She is currently an assistant professor of medicine in the endocrinology department in Emory University, and she's also the medical director of the endocrinology clinic at Grady Memorial Hospital. After the webinar today, I will send you an email with the Survey Monkey that you have to fill up and send it to me, and then I will give you the CEU credits. And if the question is going to be in the tab of Q&A question. Thank you so much, and thank you, Dr. Belanki.
Okay. Hi, thank you everyone. Thanks, Ina, for the invitation. Today I will talk about management of hypertension in patients with diabetes. You know, of course, this is something we all see kind of in concert with diabetes, and most of us manage this kind of, I think of, whenever I see a patient with diabetes, I think, okay, I got to manage diabetes, hypertension, cholesterol. So for me, it's kind of part and parcel of my management of diabetes. Okay, Ina's doing something. Okay, all right, so let's begin. Today, how do I advance this? Oh, sorry. Got it. Okay. So today I will we'll talk about review some cardiovascular epidemiology, but because really the reason we control blood pressure is we want to prevent cardiovascular disease and renal disease, which, you know, in turn can increase cardiovascular risk. And, you know, I'll go through the guidelines and how the guidelines came about. You hear different numbers: systolic blood pressure less than 140, 130, 120. What do we use? How do we do? Why do so many numbers exist? And, you know, what agents to use? I'll mainly talk about ACE inhibitors. So as I was saying before, hypertension is common in diabetes. In type 1 diabetes, 5% of patients have it by the time they're at 10 years. They have 10 years of diabetes. At 20 years, the percentage increases to 33%. At 40 years, it's as much as 70%. And a lot of people with type 2 diabetes have, 40% have hypertension just at the time of diagnosis. So there's a lot of people when you think about how many people have type 2 diabetes, and maybe even pre-diabetes, metabolic syndrome, that number increases. So what do we really care about? You know, the reason that we actually think about management of hypertension is because we want to prevent ASCVD. And I just wanted to put this definition in here because I'll use ASCVD a lot. It stands for atherosclerotic cardiovascular disease, ASCVD. That can be acute coronary syndrome. So this is going to be a heart attack, history of myocardial infarction, so prior MI, prior heart attack, stable or unstable angina, and the need for, like, you know, putting a stent in or in the heart, or putting a stent in your other arteries, so peripheral arteries, history of stroke, TIA, again, peripheral artery disease that we think it's because of a plaque, like narrowing of the arteries. So that's what ASCVD means. It's full, it's not just a heart attack. So what are the traditional risk factors again for ASCVD? One of them is hyperglycemia, as we know, insulin resistance, maybe on its own too, part of metabolic syndrome, but hyperglycemia for sure, and hypertension, of course, and dyslipidemia. and maybe some coagulation, platelet aggregation effects. And today we'll focus mainly on the hypertension aspect of it, and specifically in our patients with diabetes. And so we all know that diabetes in itself can increase coronary heart disease. So if you had no diabetes or cardiovascular or any prior coronary disease, your likelihood of coronary heart disease over time, of coronary events rather, over time is a lot less than if you were to have diabetes and a prior history of a heart attack. And all the other categories fall somewhere in between. So again, diabetes, it's just associated with high events of coronary heart disease, which goes up if you've had prior heart disease. And the one thing I wanted to highlight, just diabetes by itself, this black line over here, if you had severe diabetes, uncontrolled diabetes, you have about just as much risk as having coronary events as if you had just heart disease. Which means that if you have very bad diabetes, it's the equivalent of having like a prior heart attack or a prior coronary event, even if you haven't had one. But if you have both, that's really bad. Okay, so that's why we try to prevent, we think about how do we prevent these coronary events? How do we prevent that first heart attack, the second heart attack? And of course, diabetes, far more people, so this is all the years of life lost in patients with diabetes, both in men and women. A high percentage of deaths from a vascular cause, there's a high percentage of death from a vascular cause. Again, making, reducing atherosclerotic heart disease one of the main goals or one of the main aspects of treatment of diabetes. And so how are we doing though? There's all these trials and our diabetes care has improved. We've actually gotten better at looking at treating hypertension, things like that. And there's data to prove or show us that we're doing a good job. So this study is out of Sweden, and they looked at, what happened to coronary heart disease, coronary events, death from coronary disease over time from 1998 through 2012. During that time, we saw a vast change in what our blood pressure goals should be. There's so many studies that have come out. So if you look, for example, so this red line are people who are controls, but the blue line is people with type 2 diabetes. So overall, death from any cause has come down. Death from a cardiovascular disease standpoint has come down over time. Hospitalization for cardiovascular disease has come down, and death from coronary heart disease, so actual heart attack versus cardiovascular, all those ASCVD events that I said. So they've all reduced over time, but there's still more than people who don't have diabetes. So again, what we really need is these two, the blue and the red, to kind of match, be at the same level. That's where we need to be. I think over time, that's what we're trying to get. And the question is, what will do that? And if you look, this is a New England Journal article. This is from the United States, our own NHANES data, which shows that in patients with diabetes, we've actually reduced the amount of myocardial infarctions and strokes and amputations. They're still higher than people who die from DKA or HHS, but we've dramatically, as you can see, it's been reduced. This is events per 100,000 people. That's the y-axis. So since 1990, we've done a pretty good job, actually. And we think the reason for that is really because we were better at taking care of risk factors. So this is from that same paper, NHANES data. And I think I'm talking too fast. Am I talking too fast? Okay. This is from the NHANES data again, which shows, so these graphs, these panels, look at A is how we did with hemoglobin. All these different shadings are the hemoglobin levels. So for example, from 1999 to 2002, we had 12.6 people with the A1C greater than 10, and that reduced to 6.8. And the people with an A1C between 6 to 6.9 actually, went up from back from 1999 to 2002. And people with an A1C between 7 to 7.9 actually seem to have gone up. So, but the extremes of the A1C have come down. So moving over, if you look at blood pressure, so the blood pressure the people with less than 120 over 80, we actually went up on the percentage of people who achieved that goal. So went up from 24.5 to 32.4. And in the same vein, we actually reduced the number of people with very high blood pressure, 160 over 100, from 11.5 to 8.1%. Of course, this is all data lags a little bit, so we'll have to see what it is in 2019, 2020. And the people who have the 130 to 139, again, that percentage went down, but again, explained by the more number of people with a blood pressure less than 120 over 80. And as far as cholesterol is concerned, again, with the LDL less than 100, we increased the percentage of those people. And however, smoking doesn't seem to have changed much. But so, we think all these decreases in cardiovascular events, here, the amputations, the myocardial infarctions are likely, we postulate, one, from glycemic control, but also blood pressure, control in blood pressure as well as cholesterol. So the thing is, what should we do? What are the blood pressure thresholds? Again, just going through, we all know that this is from the UKPDS. UKPDS was a clinical trial that looked at intensive versus standard control that started way back in the 90s, looking at people with type 2, does intensive control help or not? But within that cohort, they looked at blood pressure, so it's a long observational trial. And what that showed was the higher your systolic blood pressure was, you actually increased your microvascular complications. Microvascular complications, I'm talking about retinopathy, and nephropathy, and myocardial infarction also went up with time. With increasing systolic blood pressure. So if your systolic blood pressure is 170, you had a higher risk of having a heart attack than if your blood pressure is 110, 115. And again, this is in people with type 2 diabetes. And that's an important distinction to make, because some studies did not include diabetics, or only a portion of them were diabetics. So what are the guidelines? So the American Diabetes Association says, for diagnosis of hypertension, the blood pressure needs to be greater than 140 over 90. You should add lifestyle therapy, and you should actually be, promptly, don't wait till 6 months till they come back. Be prompt about adding a pharmacologic therapy. And you want to lower your systolic and diastolic blood pressure targets to less than 140 over 90, and we'll talk about that, versus, or in some people, it says 130 over 80. In some people with high risk of cardiovascular disease, again, they say undue treatment, and I'll talk about just kind of what I do as well. And so one of the first things, in the UKPDS, this was, back in the 90s, what they did was they looked at tight blood pressure control versus less tight. So what did they mean by tight versus less tight? So less tight was a systolic blood pressure greater than 180. More tight was systolic blood pressure less than 155. And they gave them, different medications to bring it down. And yeah, right now, none of us would ever accept that blood pressure of 155 in a patient, but this was what they did. And what they found was, even reducing it to 155, the systolic blood pressure, you actually reduced stroke by 44%. You reduced microvascular disease, so retinopathy mainly, so eye disease, by 37%. Heart failure reduced by 56%, and actually in this study, death actually decreased from cardiovascular events, or death from diabetes related events was reduced by 24%. So all in all, looking, saying that blood pressure control is good. But I just gave you guidelines that said the systolic needs to be 140 over 90 or less than 140 over 90, and some that are less than 130 over 80. And guidelines are just guidelines in the way that, but they have evidence, some evidence behind it. And I always get frustrated when I'm like, what should this patient's blood pressure be? Should I aim for 130? Is it worth it? Is 140 okay? What if they're on 5 blood pressure pills and they're at 134 and they have cardiovascular disease? Should I add on something else to make it 132? So that's always a question that I have. But, I always like to look at the evidence behind, why we do what we do. So I'll present some of that. So for that, again, so I'll go through different trials that make that case for that systolic blood pressure less than 140. So what are the landmark trials? There's landmark trials that that support these recommendations. Some fields don't have it, but we're lucky in that antihypertensive treatment of hypertension does. So one of the original studies was the ACCORD study. So the ACCORD study is a multifactorial design, meaning that they looked at glucose control, they also looked at blood pressure control, and they looked at also cholesterol control to see if that reduced cardiovascular events in people with diabetes, with type 2 diabetes specifically. And what they found was that the primary outcome, which was a composite of cardiovascular events, so this was about 2,362 people, they received this intensive control. So what was intensive? Intensive was a systolic blood pressure less than 120. And they looked at it against standard, which was systolic blood pressure less than 140. And what they actually found with a composite of cardiovascular events was that there wasn't a difference. So if you targeted to 120, less than 120, and the median blood pressure that was achieved, I believe, was 115 or so, or 110. Whereas versus standard less than 140, you actually didn't have you actually didn't make a difference in cardiovascular events. As you can see these graphs, the zoomed in version of it, there's actually not that much of a difference. But the thing that and when you look at myocardial infarction, again, no difference. Death from cardiovascular disease, no difference. But the really interesting thing here is it prevented stroke by 41%. So that was evidence that, maybe the 120 could be better in somebody. That's why you get that little bit of fuzziness, when you say, okay, yes, we should aim for a blood pressure less than 140. But maybe if we really wanted to prevent stroke, 120 may be better. If a patient had a prior history of stroke and you wanted to prevent the next stroke, maybe that blood pressure less than 120 would be better. So that's where that kind of gray area comes in. And when they look, but, that 120, it was great that the stroke was reduced, but they actually had more hypotension. So they had more side effects, essentially. They had more like hives, not more, sorry. But they also had low potassium. A lot of these patients were on diuretics. And they also had elevations in serum creatinine. So 120 was, it had some good effects, but you had a lot of side effects as well. So if you look in this intensive therapy group, this is the systolic blood pressure less than 120. So, it makes the case that maybe for most patients, if you target a glucose blood pressure less than 140, you would be good. But, and the other study that makes the case for this, maybe less than 140 is the ADVANCE study. The ADVANCE study took place in Australia, but they had it was originated in Australia, but they had multiple sites. As you can see, it was 11,100 140 patients with type 2 diabetes, and they were treated with a combination of an ACE inhibitor, that's perindopril, kind of like lisinopril, all of those medications, and a diuretic, indipamide is a diuretic. And they followed them up versus placebo, and they followed them up for 4.3 years. And they didn't, so in this study is a little different in that they didn't target blood pressure goals. It wasn't like the Accord where they said the blood pressure needs to be either less than 140, or rather, sorry, one arm we aim for a blood pressure less than 140, or we aim for a blood pressure less than 120. This was just, they took everybody with, they looked at everybody with diabetes, hypertension, and they either randomized them to this medication versus placebo. And they actually also looked at not just cardiovascular events like macrovascular problems, but they also looked at microvascular problems, so retinopathy, nephropathy. And at baseline, when you look at randomized treatment, most of the patients, both patients actually had, both groups rather had a blood pressure more than 140. The systolic blood pressure was more than 140. And a lot of them had, previous hypertension, and they actually were being treated. A lot of them had a history of prior macrovascular disease, prior myocardial infarction. A few had some microvascular disease as well. So, these are the high-risk patients that would get the next heart attack or the next, or microvascular disease like nephropathy would get worse. And in trials, you do want to do this because if I were to look at just primary prevention of any kind of event, cardiovascular event, it would be 10 years, 12 years, 13 years. And no one's going to fund this. So typically trials, if you look at trials for any cardiovascular disease, they look at high-risk people. And as far as blood pressure control, both groups, so the group with the perindopril and indipamide achieved lower blood pressure. And so this was around 135. If you look on the bottom, it shows you what the achieved blood pressure was. So it was less than 140, but more than 130. And diastolic was less than 80 in both groups, although there was a significant difference over time. And then the primary outcome, again, they looked at microvascular and macrovascular events, like a combination of both. And what they found was that the group that got perindopril and indipamide actually had less micro and macrovascular events. So this is that blue line. They reduced, approximately 10%. They reduced. Adding ACE inhibitor with the diuretic reduced events by about 10% over time. And when they looked at all-cause mortality, so death from any cause, again, the x-axis is months. So this was about a median 4.3-year follow-up. And what they found was that, again, being on perindopril, so being on an ACE inhibitor and indipamide, actually reduced your death from all cause by about 14%. And so, this shows us that, and the blood pressure achieved in that group that got the active medication, the blood pressure achieved was 136, the systolic blood pressure, 135, that was about the median blood pressure. So, again, it makes the case that, blood pressure less than 140, systolic blood pressure less than 140 is actually appropriate. It can prevent, death, and it can prevent micro and macrovascular events in high-risk people. Over time, and specifically if they were on an ACE inhibitor and hydrochlorothiazide. So this was actually beneficial. So that's the case for, why most of the guidelines say blood pressure less than 140, systolic blood pressure less than 140 is okay. But what about the 120? As I showed you, there was some of the guidelines say, well, you know, sometimes lower blood pressures, 130, less than 130, less than 120 could be good. You know, what is the case for that? So the latest trial that came out was in the New England Journal about 4 years ago was the SPRINT trial. If you guys remember this, they actually had to stop the trial early. They included older people, so age greater than 50, but the average age was about 75. Their systolic blood pressure was 130 to 180, and they again had a risk of high cardiovascular events. So what did they define as high cardiovascular events? Age greater than 75, you know, at least 50% risk score on the Framingham risk score, GFR. So they had a little bit of renal disease, but they did exclude people with prior cardiovascular events, so prior stroke. They actually excluded people with diabetes, but I think we can learn things from this. And they expected and patients who, you know, had a terminal disease, they excluded them as well. And so the intensive arm was the systolic blood pressure was less than 120 versus the standard, which was systolic blood pressure less than 140. And their primary outcome was composite of cardiovascular mortality, stroke, heart failure, and acute coronary syndrome. And when you, the graph A is the hazard ratios, so the events over time. So over a 5-year period, what they found was that it actually caused 25% reduction in the intensive arm. And they actually had to stop the trial somewhat early just because they saw such good benefit starting pretty, you know, in 2 years, 3 years, they started to see that benefit. They saw the number of events have actually reduced. And so they tried to put, what typically happens is you stop the trial and you put everybody on the intensive treatment arm. And death actually also reduced. So again, if you look at this, see at year 2, you see the separation between these graphs. So that's a 27% decrease in death, in all-cause mortality. Again, intensive group, the systolic blood pressure less than 120, it reduced cardiovascular mortality and all-cause mortality in over a median of 3 years. So, you know, this gives us the case for, yeah, maybe we could aim for 120 in some people. But this study excluded people with diabetes. So is it really applicable to people with diabetes? And, you know, when you look at this, so when there's no real good data in just one study, 2 studies, we do meta-analyses, meaning you combine several trials and you try to look for, you know, for your outcome of, you know, does, for example, in here, does it change mortality? Does blood pressure change mortality? And this study was, I believe they included 49 trials, and some of them were unpublished, which is actually a good thing. If you look at meta-analyses, you should look to see if they had included unpublished data, mainly because, you know, for example, I do a study and I don't find a difference in something. It's probably important, but I'm like, it's not that interesting. I'm not going to send it for publication, right? And then the next person does it, and the next person does it, finds the same thing. If it's reproducible, something, it's important to know. You know, it's important to publish negative studies, but not all of us do it. So it was good that this meta-analysis actually included a lot of unpublished data. And what they looked at was, well, what is the all-cause mortality? What is mortality? Or cardiovascular mortality, myocardial infarction, if your baseline blood pressure, where they use different cutoffs. So, and the left part, so says favors treatment, or you favor, you know, control or no treatment. So when they looked at baseline blood pressure, if you had a baseline blood pressure greater than 140, you need treatment to reduce mortality. Again, same thing. If your blood pressure is more than 150, you needed treatment. And however, and if you especially wanted to reduce stroke, you needed treatment if your blood pressure was more than 140 for sure. Heart failure, again, 140, greater than 140, you need to treat it. So as it goes on. So, and then they looked at what was the attained blood pressure in those studies. You know, if you went from 150, you know, if you attained a blood pressure of 140, they didn't look at delta, like if you went from 180 to 150, what was the benefit in this particular meta-analysis? But they just looked at what was the attained blood pressure, systolic blood pressure. And mind you, there's only one study that really looked at diastolic blood pressure lowering, like a clinical trial, but most of them look at systolic blood pressures. And what they found was, you know, if you wanted, with all-cause mortality, if you wanted to reduce that, you probably had to achieve a blood pressure between 130 and 140. Again, this is a meta-analysis. And if you went to less than 130, actually didn't make a difference. Maybe because, you know, all those side effects I showed you in the ACCORD study, like hypotension, creatinine going up, hypokalemia. If you wanted to reduce cardiovascular mortality, you had to attain, well, here the confidence intervals are a little but if you really want to reduce myocardial infarction, you really should get the blood pressure to be 130. Here it says 140, so I don't, but really where it makes the difference, similar to our ACCORD trial, is the stroke. If you get that blood pressure less than 130, then yeah, you prevent stroke. And so, you know, this is the, and another study, this is the study by, this is another meta-analysis that looked at the reduction of cardiovascular disease. You know, does blood pressure reduction reduce cardiovascular disease and mortality? And they had a pretty cool, this is a pretty cool, like, a graph. I've never seen this in a meta-analysis before. So what this shows is that this is the baseline blood pressure. These are the number of trials where the goal attained. So this is where they started. This is what they went to. Again, same thing. This is the number of trials, represents achieved systolic blood pressure categories. Again, that assess these comparisons, going from this to this, going from this to this. There's only 2 trials. Going from this to this, there's only 1 trial. So, and so on. But a lot of the trials went from 130 to 125. And a lot of these, again, you have to remember they're from cardiology. So they include a subset of patients with diabetes, but not always. And if you just look at overall population, the people, yes, reduction, you know, 120, 124, if you achieve a systolic blood pressure that's in the 120s, overall you have less events. Again, in the 130s, especially if you started off a little bit higher, that's where you see the most benefit. And if you reduce to 140, again, if you start off pretty high, then you do see a benefit if you get your blood pressure to 140, 144. And same with the 150s, you see less of a benefit. Again, you have to remember not every one of these trials had a lot of people with diabetes. Some did, some didn't. And so what does that mean for me? So in a way, I think about it like this. If I have a patient with a blood pressure more than, you know, 160, I know I have to start something, right? And we do. And say I did achieve a blood pressure that is, for example, I started at 150, but I did achieve a blood pressure, systolic blood pressure of 131, and they had a history of stroke or cardiovascular disease. And they're on 3 medications. They're on an ACE, they're on a beta blocker, they're on a calcium channel blocker, beta blocker, sorry, calcium, and a diuretic. Do I add a 4th one if it's going to add the burden of disease? Probably not. I may be okay with the blood pressure of 132. So that's what that means. So that's what I interpret this as. And what about the JNC guidelines? They actually are in accordance with a lot of the diabetes trials. And what they say is that in patients with who are aged between 18 and 59, although if you're 18 and if you have high blood pressure, you should look for other causes. And in patients 60 years of age or older who have diabetes, the goal blood pressure should be less than 140/90, is what they say. And then, and then the clinical practice guidelines from all these societies, so all the heart society, cardiology societies, again, they all say, less than 140/90. And what they also say is, individualized treatment. I think that's what you'll see in most guidelines, and that's what we do anyway. Again, guidelines are guidelines, but I wanted to show you some of that data. What they ask you to do is estimate the risk of cardiovascular disease, because that's, when we think about treatment of hypertension, that's what we think about, right? The end goal is, but the one kind of caveat to this risk estimate is that it doesn't account for, it does say, do you have a history of diabetes or not? And it does increase the risk of cardiovascular disease if you say, yes, a person has diabetes. But it doesn't, a person who just got diagnosed with diabetes is a different person than someone who had diabetes for 10, 20 years. So it doesn't account for that duration, that the amount of, damage you get from or atherosclerotic disease that you have. And it also says, what's the blood pressure and have they been treated for hypertension? But it again doesn't account for how long you've had hypertension or any of these issues. And it also doesn't account for albuminuria, which is again a risk factor for cardiac disease. But what they do say though is you should, when they look at primary and secondary prevention, they actually, given all the trials, they actually, and they don't specify diabetes, they say the BP lowering medications is recommended for secondary prevention. So maybe if they've had prior cardiovascular disease, it should be less than 130 because of that reduction we see in stroke and the meta-analyses that I showed you. And then primary prevention, primary prevention as well, if the estimated that ASCVD risk score is 10% of higher, then, go for that systolic blood pressure 130. But if your 10-year ASCVD score is less than 10%, maybe 140 is okay, actually. But again, it doesn't account, this recommendation doesn't account for duration of diabetes. But at the same time, it's a good goal to have. And I don't think we have those trials where we randomize or stratify people for and change, blood pressure goals based on duration of disease. So what does the ADA say? Again, so they say, as I put it in before, again, patients with confirmed office blood pressure greater than 160/100 should have, again, prompt therapy. So how do you achieve this, and what do they mean by lifestyle? So weight loss, if appropriate. So weight loss, you can reduce blood pressure by about 1 millimeters mercury. DASH style diet, so low sodium, you can reduce blood pressure by about 5 millimeters mercury. So which is actually could be significant, if you have a patient who's at systolic blood pressure of 142, 143, and they need to come down, a DASH style diet could work. Of course, unless they have albuminuria, then you may want to do an ACE inhibitor. And weight loss, if they're overweight, in that particular patient, a lifestyle could work. But if they're greater than 160/100, most of the time they do need to have medication to bring this down. And I'll go through the diabetes consensus guidelines as well, but the other question we always see, and sometimes I'll see this, is, and my students and residents and fellows will ask me, well, the patient has diabetes, should they all be on an ACE inhibitor? Should everybody be on an ACE inhibitor? And the short answer is no. So, and why would you want to use an ACE inhibitor? We know that ACE inhibitors, they protect against progression of microalbuminuria. So they do show that they do decrease the progression of kidney disease. They may slow the progression of retinopathy, actually. And there's some data that shows maybe they increase your responsiveness to insulin. And so this, again, when you don't have a definite answer, you do a meta-analysis. And this meta-analysis showed that, if for example, if you, in patients with diabetes, if they didn't have, if you had normotensive patients and you've put them on an ACE inhibitor versus a calcium channel blocker, there's no change in outcomes. And all these other studies showed similar. Again, if you looked at ACE inhibitors versus diuretics, again, no difference. So what this tells me is that you got to get their blood pressure down. Where it makes a difference is if they have albuminuria. So how should you treat hypertension in these patients? An ACE inhibitor. If they're not tolerant of an ACE inhibitor, and your angiotensin II receptor blocker, so these are medications like losartan, valsartan, a thiazide, so a diuretic, and calcium channel blockers like amlodipine, nifedipine, the calcium channel blockers that end with PINE, pine. And typically, you need multiple drug therapy to achieve some of these blood pressure targets, just because, the lifestyle, they do make a difference, but not if you want a reduction of 10 millimeter mercury, they don't show a significant difference. Rather, they won't reduce it to your goal. And that's what I tell patients too. Some of my patients are like, wait, I'm already on one blood pressure medication. You're telling me I need another one? Can I switch it out? Maybe the first one isn't working. I'm like, no, it's a progressive disease, so you probably will need more. So I set that expectation initially. Say you may need more. You'll probably be controlled, but maybe you'll need more. Again, the main goal for us is to reduce your cardiovascular disease. And we're going to do things to bring your risk down. And again, we should have patients be on an ACE inhibitor. Again, that's the first line treatment if they have diabetes and albuminuria. Okay. If they can't tolerate an ACE inhibitor because they have angioedema, this is the only time where you substitute. You do an angiotensin receptor blocker. There's no evidence that both of them together will help. And if you are using ACE inhibitors or diuretic, monitor creatinine and serum potassium levels. And to kind of bring it all together, this is a consensus guideline. And the ADA, they say, and this is a good thing that I have in my mind. So, and when I teach my fellows and students, what they want you to do is, when somebody you diagnose you diagnose someone with high blood pressure, if this is their starting blood pressure is greater than 160 over 100, just do lifestyle management, but you're not going to achieve your goal of 140 with just one agent or with just lifestyle management. And typically you want to start with 2 agents. And then if they have albuminuria, then you think about doing an ACE inhibitor or a calcium channel blocker and diuretic. If they don't have albuminuria, you could do, they want you to start with 2 drugs, and you can pick from any of these 3. But if they have albuminuria, definitely do an ACE inhibitor or an ARB, and you can choose another agent. I didn't go through the trials that did combination pills, which showed combination pills probably have better adherence. So you can do lisinopril with hydrochlorothiazide combo. That shows that maybe they're better because of adherence issues. If they have, blood pressure less than between 140 and 160, you can get away with one agent. But if they have albuminuria, start an ACE inhibitor. And then you assess blood pressure control. And then if you meet your goals, fine. Again, You may want to consider, for all patients, you want to do less than 140 systolic blood pressure. But then if the patient had a history of stroke, if you want to prevent stroke, if they can tolerate the therapy, meaning that they know when they're hypotensive, you're monitoring them closely, I will do a blood pressure goal of less than 130. And so in summary, the point of reducing blood pressure in our patients with diabetes is to reduce cardiovascular events, ASCVD. Our blood pressure goals for patients with diabetes, for most patients, less than 140 over 90. For patients at high risk, less than 130 over 80. Or sometimes, if you can tolerate 120 over 80. Individualized therapy, ACE inhibitor or arb-albuminuria, otherwise just reduce that blood pressure. One thing I want you to keep in mind, all the studies were done in patients with type 2 diabetes. There's no real good randomized controlled trials in type 1s with blood pressure. So we extrapolate what's from type 2 to type 1. But I just want you to keep that in mind. For example, a 3-year-old who's had diabetes for 10 years, type 1, and their blood pressure is 140, do you want to put them on a medication for the rest of their life? That's a person you want to do aggressive lifestyle treatment with. So in that way, you got to think about it a little bit more in patients with type 1, okay? So that's it. I will take any questions.